To know the role we play in cancer care, we need to understand what cancer care means to us individually and collectively. As healthcare professionals, whether you're in the clinical practice or in the community, is cancer care solely within the parameters of your daily work, or does it go beyond? Will bridging the gap be a seamless extension of your work, or like me, a meandering journey which brought me to focus later in life? When I decided to go to medical school, I didn't have that many people ask me the usual questions you might get of, why did you do medicine? It could be the fact that I come from a family of doctors. My father was a radiotherapist, my mother a GP, a brother already in medical school, and countless of relatives along the same path. But if you asked me then 30 years ago, I really didn't have an answer. However, horrors of horrors, when I decided to leave medicine a decade later, I did have a clear answer to the questions and comments of how could you, why did you quit medicine, the money spent, the years wasted, etc., etc. The questions were endless. Going back to my childhood, my lunch and dinner time family conversations revolved around two subjects: golf, which we will not talk about today, and patients seen by my parents, the type of issues and how they were resolved. Of course, for my father, it was all about cancer, how the treatment worked or not, new technologies, all very clinical. On my mother's side, it was about the house calls, how patients reacted to their diagnosis, how they were managing their side effects of treatment, or in some cases, non-treatment. I didn't realize until much later, after I lived through my mother's cancer for the first time, that I was actually seeing two sides of a coin: heads, the clinician, and tails, the doctor's perspective of the patient. When my mother was first diagnosed with ovarian cancer, I was still in medical school. Our experience mirrored that coin. My mother already had spinal and organ impairment from a previous spinal tumor. So we, her advocates, poured through research on treatment options, weighing pros and cons based on her impaired status, and decided the best course of action. Despite all that, the reality was she had less than a 10% chance of living. I'm relieved to say we beat the odds. Note, I said we. We patted ourselves on the back and moved on. Move 5 years on. I'm a medical officer. Mum is now diagnosed with breast cancer. She's being treated in the same hospital as I am working. So I decided to stay with her as her carer while she was in the surgical ward awaiting her breast surgery. Here we were, two doctors, sitting in the ward amongst other women in similar positions. Slowly, very timidly, a question would be asked, and then another and another. Suddenly, we nearly had the whole ward sitting around us. The questions, though, weren't what we were expecting. They weren't about the technicalities of the surgery. They were about, will I wake up after surgery? Will I still be a woman? Will I live? Will my family, my husband, still love me? Will I be abandoned? It was then that I realized the two sides of the coin analogy was all wrong. Yes, one side is definitely the clinician, but the other, the tails, was not the physician or the patient, but had to be the actual patient. That when Mum went through her ovarian cancer, we failed her. We didn't take the time to hear her voice. And to all the budding clinicians listening to this, you might say, we know this. We've heard this all from our lecturers, or maybe from the Bibles of medicine, Gray's Anatomy, The Good Doctor. So, why make such a big deal about it? Why? Because it's harder than it looks. We, as healthcare professionals, are trained to act from the perspective of the clinician. Is that bad? Yes and no. Yes, acting as clinicians, we get technical improvements, enhanced treatments, and ultimately better outcomes. But to utilize all that know-how in a meaningful way, we have to first get the patient to the table in a timely manner. And secondly, we need to be able to keep that patient engaged. And that is a lot more complex than we imagine. And to the question of what drove me away from practicing medicine, this was it. It wasn't just the frustration of seeing patients come in at late stages when near to nothing can be done. It was the greater impotence you feel when a patient turns down your treatment because they're afraid, or when you see them months or years after diagnosis in a worse state physically and mentally, knowing you could have done something but didn't. That can break you. In cancer, getting the patient to the table is so incredibly important. And yes, as cliché as it sounds, it can be the difference between life and death. Equally as important, it could be the difference between a life of suffering, the after effects of cancer, to one of rejoicing, a life with cancer. And in this, the role we play in bridging the gap in cancer care is essential. This is what brought me back to medicine. Malaysia is an upper middle class country, aspiring to be a high income country. Yes, we definitely have the economic trappings of an upper middle class society, tallest twin towers, amazing infrastructure, hundreds of shopping malls. Our healthcare parameters, though, speak a different story. A story of rising rates of obesity, diabetes, heart disease, and cancer. Pre-COVID, non-communicable diseases, or NCDs, including cancer in Malaysia, accounted for 73% of all deaths. 35% of those were under the age of 60. In 2016, this accounted for 67% of all premature deaths in Malaysia. The majority of cancer cases in Malaysia are in stage 3 and stage 4, leading inevitably to an early death. Even in breast cancer, 42% are found in late stages, and survival rates are only in the mid-60% range, when it should be in the high 80s. These are premature deaths, preventive deaths. To give you another perspective, in 2020, these NCDs cost the Malaysian economy over 8.9 billion ringgit due to productivity costs from work absence and premature deaths of working age population. NCDs also place a serious health burden resulting from disability and loss of healthy life years. This is called the burden of disease costs. This intangible cost is estimated to be around 100 billion ringgit, equivalent to 7% of our GDP. So what did we do? How did we combat this? In 2018, Malaysia spent roughly 3.8% of its GDP on healthcare. Okay, that's not much, but what did we spend it on? In 2014, 69% of the health budget was spent on curative care and outpatient goods, and only 7% on prevention and public health care services. In 2018, 6.2% of total spending on health, both private and public, was spent on preventive care. 6.2%. We know two things from the above. One, our healthcare spend is definitely insufficient. And two, we need to optimize the spend for a more sustainable impact. What if? What if we shifted the healthcare spending from treatment to preventive and early diagnostic interventions? We know from economic modeling, investing $1 in a set of core preventive strategies will save over $7 in treatment costs. What would that mean to cancer care in Malaysia? But wait, what is cancer care? Knowing the above, that we may actively stop premature deaths from cancer, where does cancer care start? From the point of diagnosis of cancer? Or does it start much earlier? On the other spectrum, where does cancer care end? When the treatment is completed? Or when the patient dies? You might be interested to know, There is no universal definition of cancer care. Medically, it is defined as the care and treatment of patients with tumors or cancers. 20 years ago, that meant providing the optimum treatment for the patient, just as we did for my mother. Did we treat her cancer? Yes, definitely. Did we make a positive difference to her life? Probably not. That was 20 plus years ago. Today, we speak of patient-centric care, the goal being to empower patients to be active participants in their care, respecting their needs and healthcare choices. But as I said earlier, it is not easy. It is no longer the dispensation of a treatment, writing up of notes and closing of the patient's file after treatment. We have to put ourselves in their shoes, walk in their carers' shoes, feel their anxiety, be there for them on their terms, not on our time clock. There are models for patient-centric care. It is engaging not just with the patient, but with other partners, other healthcare professionals, allied professionals, social workers, counselors, dietitians, peer support groups, non-profit organizations that support the patient's journey. This engagement has to start from the beginning, not from once your formal role is finished. The building blocks are all there. If you can imagine the Scrabble board in your mind, you start with one word. From there you build different words, all interconnected but separate. That is what cancer care is all about. Connections of services and peoples built from one root word, that being the patient. So you might ask, how does that really make a difference? Imagine patient A and patient B, both women with breast cancer. Patient A had regular screening. She found microcalcifications in her mammogram. She went on to have a lumpectomy and hormonal therapy, and all is well with her. Patient B found a lump by herself. However, unlike patient A, she was not offered a mammogram. The surgeon decided to do a lumpectomy. Her resulting HPE showed cancer with unclear margins. Her cancer was probably in stage 3. She had to go back, do another surgery, do a mastectomy, chemotherapy and radiation. 10 years down the line now, she's battling a recurrence. What was the difference between these two women? Different countries, different times? No. The only difference was 30 kilometers between where these women lived. KL and Klang. But the treatment difference was the distance between the sun and the moon. Let's play what if again. What if patient B was offered a mammogram? Maybe there were no facilities close to her, or she couldn't afford the services. Studies have shown that women with advanced disease had to travel longer distances to facilities versus those in early stages. It also showed that being provided free or subsidized mammogram increased chances of service uptake. So what if? What if patient B was offered transport or a free or subsidized mammogram? How different would her journey have been? She definitely would have had less surgery and she would have clean margins. Now, what if? Picture how different her journey would have been if these services were offered as a screening platform, not diagnostic. She would not have been diagnosed at stage 3, and in all probability, her journey would have been similar to that of patient A. All it needed was a free or subsidized mammogram and transport to make all the difference. Another area of potential change and impact. We know treatment abandonment or failure to start treatment is a phenomenon seen here in Malaysia. It is a major cause of treatment failure for both adult and childhood cancer. What can we do about it? There are success stories out there. In a Vietnam hospital, treatment abandonment rates in children with ALL fell from 50% to less than 1%, purely from the establishment of a patient group and providing transport to the hospital. Locally here in Malaysia, the National Cancer Society of Malaysia has targeted efforts to address the same issues among patients and caregivers through the establishment of psychosocial support, lodgings, transportation, setting up of support groups and helplines. But these little things, these baby steps, need to be placed coherently and strategically. That's where working together becomes so important. It is building an ecosystem in place which is sustainable and dependable. So in conclusion, what is the gap in cancer care? What role are we to play in bridging that gap? The gap is whatever you perceive it to be. The gap is where you feel helpless or frustrated because you are unable to care for your patient in the way they need to be cared for. The role you play is where you are willing to go beyond your parameters of care to provide solutions that will make a difference to your patient's survival or even a difference to their manner of death. The cancer miracle we're looking for is not a cure. It's engagement. That's how we bridge the gap. So at your dining table, whether it's with your colleagues, friends, family, or one day, your mentees and trainees who look up to you and seek your guidance, what will your conversation be? Will it revolve around the clinical aspects of cancer care? Or will you offer them a different perspective? The choice is yours to make.